Good afternoon, and thank you for joining today's event, Cybersecurity. It's more than HIPAA, New York Regulatory Refresher for 2024. Today's session is presented by Ed Keck, partner and market leader of Withum Cyber and Information Security Services team, Stacey Gulick, partner and chair of HIPAA, Privacy and Risk Management at Garfunkel Wild, and Michael George, partner and healthcare leader at Withum. Before we begin, let's review a few housekeeping items. At the bottom of your screen, there are multiple tools that are resizable and movable, so you're welcome to move them around as needed. You can expand your slide area or maximize it to full screen by clicking on the arrows in the top right corner. If you have any questions during the presentation, please submit them through the Q&A tool. We will do our best to address them. Today's slide deck will be accessible in the console view after the webinar, along with the recording of today's session and additional materials in the related content tool. Please download any resources or links that you may find helpful. With that, I'll turn over to Stacey to get started.
Hi, everybody. I am going to go through just a quick summary of the proposed regulations, and then we'll get into the meat of what you need to start doing in order to implement these requirements. So as you know, recently New York State announced proposed cybersecurity regulations for general hospitals throughout New York State. And just to clarify, because the term hospital in New York is a little confusing, so the term hospital, just by itself, means any Article 28 facility, basically. The term general hospital refers to basically Article 28 facilities with an emergency department. So if you're not a general hospital, these regulations do not apply to you. So when these regulations are finalized, the general hospitals will have 1 year to comply with the requirements of these regulations, except that it is proposed that there is a cyber incident reporting obligation, and that is anticipated to go into effect as soon as the final regulations are published. So we had until February 5th, 2024 to submit comments to DOH, and that comment period has obviously passed, and we are now waiting publication of the final version. So we don't entirely know what it's going to look like. Typically, I don't know, 85% of what they publish in proposed form is what ends up living. So if you want to get started early, I think you can really rely on the proposed regulations because they are also best practices, which Ed is probably going to talk about a little bit more. But these are really reflect the best practices anyway. So you're not doing anything unnecessary or that you're going to have to toss out the window. These practices are a good idea. So one last point, and some question I think a lot of people have, and probably is the focus of the rest of my discussion, is are these regulations the same as HIPAA? Yes, in many ways they are the same as HIPAA, but they have more obligations than you are currently required to do in addition to HIPAA. And we're going to point out those high-end things, those bigger issues that you're going to need to address, even though you have a HIPAA compliance program. So you have to comply with both HIPAA and these regulations require you to do more than HIPAA does. So we're going to start out with, okay, how do these proposed regulations align with HIPAA? So first of all, there's things like you have to conduct a security risk assessment. Like HIPAA, these regulations require your entire compliance program to be based on your security risk assessment. Sometimes we call it a security risk analysis. Sometimes we call it an SRA. You know what I'm talking about. So and just a reminder that the Department of Health and Human Services, the federal department, has come up with a really good tool. It might be a little simple for hospitals, but it is something to take a look at to assist you with your risk assessment process. They've been perfecting that for some time, and it is a lot better than it first was. And then you have to have a whole plethora of policies similar to what you do for HIPAA: user access credentials, role-based access, secure disposal, encryption, disaster recovery, all those things you do for HIPAA. They're going to work to help you also comply with the New York proposed regulations. You're going to continue to have a security officer. It is referred to as a CISO, Chief Information Security Officer, under these proposed regulations. It is important to note, though, under the New York regulations, the CISO must be a senior or executive level position, right? So HIPAA didn't specify the requirements for a security officer. These New York regulations require it to be a senior or executive level position. Like HIPAA, all your documentation of compliance has to be retained for 6 years, and there has to be a whole lot of cybersecurity awareness training, which we all would expect. Now, so that's just a quick snapshot of what is good, like you already probably have in place. Now, what else are you going to have to do, or how are these regulations different than HIPAA? So these regulations don't just apply to patient information or PHI, protected health information. These regulations apply to all non-public information, which is defined much more broadly than PHI, and includes the hospital's business-related information. So that means that when you're drafting these policies or doing whatever you're going to have to do, they're going to need to apply to all of your protected health information and all of your confidential business information. And I think that's a pretty big change, and something that you're going to have to work through and maybe want to start working through right away. In addition, the policies that are ultimately drafted in order to comply with these regulations will need to be approved by the hospital's full governing body. And it's interesting to me, I don't know if this will come out in the end, but the proposed regulations don't allow a committee to approve it. It has to be the full governing body, which is kind of unusual. And in addition to that, if the CISO, who we talked about before, is not an employee, so you can have a CISO that's not an employee, but the governing body, the full governing body, must approve that contract as well. So we're seeing a lot more involvement of the governing body in these new regulations than is typically required of HIPAA. In addition, just to prove another aspect of this concept, the CISO must report in writing at least annually to the governing body on the hospital cybersecurity program and material risks and that type of thing. So there must be an annual report from the CISO to the governing body, once again, not present in HIPAA. You have to conduct penetration testing at least annually. This is different than the security risk analysis. This is a true pen testing requirement. For those of you who have never engaged in pen testing, it can get expensive. So it is definitely something to keep in mind when budgeting process. I personally think that penetration testing is a great idea, and you should be doing it anyway, because it really can reveal vulnerabilities that you did not previously identify, but it is proposed to be required under the regulations. And you must conduct automated scans or manual or automated revisions of information systems to identify cybersecurity vulnerabilities. HIPAA requires you to do some review of system activity and that type of thing, but it does not specifically get to, hey, you need to do automated scans. And again, this is a great idea, because that's how a lot of these hackers get in through phishing attacks, or they get in through open portals. And these types of automated scans are designed to assist you in finding those open portals. A little bit more we can talk about here. The policies address another big area in which these regulations are different than HIPAA is that there is a lot more requirement to keep an eye on what your vendors are doing. You have to specifically require vendors not only to have a business associate agreement as you do under HIPAA, but you must require them to have access controls that are consistent with industry standards. So that's really username, password, multi-factor authentication, that type of thing. They have to both have encryption at rest and in transit. So your vendors need to, in writing, agree with that and approve that and do that. And they have to be able to report security incidents. Probably that's in most of your business associate agreements, but again, under the New York regulations, they are now specifically required to do that. And remember, it's not just security incidents involving PHI, it's security incidents involving any non-public information, including business secrets. So it's a bit broader. Hospitals are going to have to implement multi-factor authentication. Hopefully most of you have done that anyway. It's a great security tool. Then you must have policies that address how you develop applications used by the hospital, which also is not something I've really ever seen in HIPAA. So you can see that there's a lot of things coming down the pike, and I'm going to go into a few more that are more. You're going to have to spend some more money. You're going to have to revise your policies. This is a big deal. And finally, not finally, I think I have one more slide after this. You have to establish a written incident response plan. I work with a lot of different facilities, and I don't know that everybody has a written incident response plan that includes all of the elements listed here. So more and more, even the OCR, even the federal government is saying the entities need a well-developed incident response plan. And then to jump on top of that, what I'm hearing from insurance companies, your cyber insurance companies, is they also want to see or even dictate to you what your incident response plan looks like. So not something to just tuck on a shelf and forget about. You're going to have to pull that out and really update it. Finally, it's this reporting obligation, and it's a 2-hour rule, which is, wow, this is fast. So once the regulation is finalized, you're going to have to immediately comply with the 2-hour reporting rule. In other words, the CISO or other person must notify the Department of Health within 2 hours, 2 hours, that's very fast, of a determination that a cybersecurity incident had a material adverse impact on the hospital. So that's not quite 2 hours when you learn something happened. It's 2 hours after you've determined that it was a cybersecurity incident and that it had a material adverse impact. So you have a little time after saying, something's a little wonky here, let's look into it. So you have a little time to look into it, but once you figure out that this standard has been met, you have to tell the Department of Health in 2 hours. So how is a cybersecurity incident defined? So I hate to read things, but I'm going to read this one so you really get a sense of it. It's an act or attempt, successful or unsuccessful, to gain unauthorized access to, disrupt, or misuse the hospital's information system or information stored on such information system that first either has a material adverse effect on the normal operations of the hospital, so it interrupts the hospital's ability to provide care, or has a reasonable likelihood of materially harming any material part of the normal operations of the covered entity. And it's interesting to me, I don't know why they used covered entity there rather than hospital, but maybe we'll get some clarity on that. And then results in deployment of ransomware. So if any of those things happen, if you have a security incident that disrupts your normal operations or is reasonably likely to disrupt your normal operations or is ransomware, you must report it to the Department of Health. So I think that covers my very, very quick snapshot. I know I talk really fast of what the cybersecurity regulations look like, where you need to focus, where you probably already have compliance, and then we're going to move on from there. Thank you.
Excellent. Well, thank you, Stacey, and good afternoon, everyone. And so next, as Stacey mentioned, Stacey kind of went through some of the background. And so we figured that we would go through some Q&A that hopefully will be helpful to everyone. We also have a Q&A box. I know that a few questions have been put in there, so we'll try to address throughout or at least at the end of the presentation. But we certainly know that healthcare organizations have been a target for cyber attacks, and clearly that impact has been devastating financially, clinically, and from a reputation perspective. Just recently, all of us witnessed, and for many on the phone on the call today, actually dealt with directly the fallout from Change Healthcare and the significant impact that had on every corner of the healthcare ecosystem. It was even in Becker's today that maybe some information has been leaked on the black web. So again, really can be devastating to an organization on a breach. So we're going to talk a little bit now about maybe some of the why. And Ed, I'm going to bring you in here since Stacey's done a lot of talking here for a while. Let's discuss why we think that New York State kind of fast-tracked, this regulation and, to have a more comprehensive cybersecurity program at general hospitals, and certainly the aggressive timeframe attached to that. Can you maybe give us a sense of your thoughts on that?
Sure. There's kind of a short answer, and then let me back that up with some things that we're actually seeing in the industry from a security perspective, and maybe a few stats here and there. I don't want to bore everybody with numbers, but the short answer is hospitals, in general, medical practices of all types have become primary targets of hackers because of the kind of treasure trove of information that they hold, right? If you think about it, if you unfortunately have to go to the hospital, not only do you have all your health information, you have your personal information, or name, address, phone number, all of those things. You're also likely to have payment information that's been divulged to the hospital. Okay, so they really sit on kind of a gold mine of information about individuals. That's the short answer. To back that up a little bit, according to the U.S. Department of Health and Human Services, 85 million patients have had their personal information compromised. In the first 9 months of 2023, and that's kind of the latest stats that we have, and that's compared to 38 million for the same time period the year before. Okay, and then nearly 25% of cyber attacks in 2022, and that number went up in 2023, targeted the healthcare industry, and data security, just continues to be a challenge in this space because of the volume of the data, right? Additionally, when you look at this, our team, as well as others in the industry, are seeing a significant shift in where these attacks are taking place. So what we're seeing is that these attacks are moving from the large institutions, whether those are healthcare institutions or financial institutions, doesn't matter, to the mid-size and the smaller institutions, because the hackers and the attackers feel that they will have less defenses in place. And what we're seeing right now is that approximately 46% of all cyber attacks are targeting medium and small size organizations. So that's where I think New York felt that they have to do something to protect the citizens of New York, given the focus that's been placed on healthcare organizations by the attackers, as well as seeing the attacks move kind of, I'll say, downstream from the largest of organizations to really any organization that holds the information.
Yeah, and Ed, I could imagine some of the smaller or mid-sized organizations probably don't have the same level of funding and resources to really put the sophistication in around the systems and everything. So in some respects, they might become an easier target.
Right, and that's where Stacey Stacey did a great job of outlining some of the differences and making some things very clear, especially for mid-sized and smaller organizations. It's clear that you can your CISO, your cyber professionals, to have a full-time cyber architect, right? To have a full-time chief information security officer or chief security officer, that can become quite costly. Okay, as a former CISO and a former chief architect for in a couple of highly regulated environments, those people are hard to come by and they can be expensive. So, for the mid-sized and smaller organizations, really think about what is it that you need, and can I get a fractional security officer, a fractional chief architect? There are options for that, and just review their credentials, and that gives you the expertise you need.
Yeah, no, absolutely. Thanks, Ed. Stacey, anything to add around, why hospitals are being targeted and the incentives there before we kind of move on to some others?
So I totally agree with what Ed was saying. I think the other thing that I see at hospitals versus other healthcare providers is hospitals are much more complex. So they don't just like a physician practice probably has an EMR and maybe it's integrated even with their billing system. So they might have two, they might have an LIS, a lab information source system, depending what they do, but they don't have a lot of complexity. Hospitals have a lab information system, their EMR, their billing system, their pharmacy system. They have ultrasound machines that have PHI on the hard drives. I just dealt with the breach this week on that. They have so much more complexity than other types of healthcare providers have, that it's hard for them, I think, sometimes to remember everything, radiology, this, that, and the other thing, to remember to keep an eye on everything. Everyone keeps an eye on the EMR, right? Because that's the biggest thing. But there are many, many other vulnerabilities. So that is the other reason I think sometimes that the hackers attack hospitals, and the state wants to make sure that hospitals have a comprehensive cybersecurity program in place.
Absolutely.
Yeah. So I was just seeing this. Hi, Sandy. I saw you sent me a question. So I think that is right. I think you're right. I think the reason they used cover. So Sandy was saying where I had previously said, I'm not sure why they changed the term from hospital to covered entity. I think, and Sandy was asking, is that because others than the hospital, other covered entities than just the hospital use the EMR or their IT systems? And that's right. Usually hospitals have physicians coming into their IT systems, maybe vendors, maybe payers. So they want us to talk about incidents that affect any of those types of covered entities. And there's a couple other questions here I can quick hit for you guys before we move forward. So will third-party companies be required to present a SOC report? Currently, that is not proposed. However, I have plenty of clients that do require that. Not a bad idea. You know, so many times I'm seeing breaches caused by vendors that you do want to have some way, and I don't, various different resources available to you to actually monitor and manage your vendors. I think hospitals need to look at that more and more. But a SOC report is not technically required at this time, or proposed to be required.
Sorry, Stacey.
No.
I was just going to say, add, as it relates to third-party management, maybe you want to weigh in on maybe that, because it's obviously some that do a SOC report is costly and everything that goes into that, but there's other ways to try to help mitigate that third-party risk management, correct?
Yes, absolutely. First, I would say leverage all the tools at your disposal, right? So it never hurts to ask for the SOC report, but if they don't have it, that's not the end of the world, right? Especially if your third party provider is a small organization, right? Then you want to ask them. You want to have a questionnaire that asks them about the primary controls that they have in place, and you want them to be able to fill that out and inform you of what they're doing to secure your data, right? Or the data that you are a custodian of on behalf of your patients and employees. So there are other ways of doing it. What I typically advise is, keep it short and sweet. From an ask perspective, but it doesn't hurt to ask for a SOC report. And if they say they don't have one, there are other ways to get assurance that they are covering security appropriately.
Okay, great. And I think somebody asked about the actual name or title of the regulation. Sunil, I think you asked that, and it's 10 NYCRR F 405.26, and I'm actually trying to put it into the Q&A, having a little problem right now, but we'll get that in there so everyone has that if they want to look that up.
Sunil also asked about the difference, the comparison of the cybersecurity regulations to the Cures Act. So they're actually dramatically different. The Cures Act is about promoting interoperability and requiring entities to share information. These cybersecurity regulations are about protecting the information, not preventing the exchange of information, but making sure that the information, while it's being maintained or exchanged, is being protected.
Great, thanks, Stacey. So maybe we switch a little bit to the type of attacks that we're most commonly seeing with hospitals. Maybe Ed, maybe I'll start with you, and Stacey, I'll come back to you if any additional thoughts after that. But Ed, I think this kind of fits in your wheelhouse.
It does, but I'm also sure that Stacey has seen her share of attacks that her clients have undergone from breaches. But really and truly, we're seeing. I hate to say we're seeing everything, but we really are kind of seeing everything. We're seeing ransomware attacks. We're seeing, we're seeing kind of, brute force is probably the least that we see. But if people are knocking on your door, and this is why, Stacey highlighted a pen test and said that, it's really a good idea, even though it hasn't been mandated prior to this, it's really a good idea to have been doing them. The pen test and the vulnerability scan will help prevent that kind of brute force, oh, is the door open? Can I just get in? Kind of attack that we see. We have seen some, and we saw one recently with a healthcare organization where and attackers got in through the website, through their front door. And because of the way their environment was configured, once they were on the website and on those servers, they were able to get to the internal servers, and they had admin rights, and they were able to start jumping around to all of the servers that had PHI on them, as well as other information. So, that penetration test that will identify vulnerabilities, or the vulnerability scans internally, are critical, because sometimes it's those things like, oh, I didn't patch the system, that allows them to exploit that and move between servers. So ransomware and that kind of, let's knock on the door, and if we get a response, let's go see if we can get in there, have been we see them all the time. And then we do see a little bit of business email compromise, where someone will get an email, they'll click on that email, they'll get malware that will get launched. The important thing that I'll tell you is we also see these attackers, they like to sit in the environment for a while, kind of scan it, see what's out there, and they don't just start grabbing information right away. They'll sit there for, a period of time. Sometimes it's weeks. Sometimes I've seen them sit for months, until they're very comfortable with knowing where the gold is in the gold mine, and then they start to extract it. So those are really the three big items: business email, ransomware, and still a lot of the knocking on the front door. And if we get a response, kind of brute force our way in. I'm seeing all of those. Stacey, what are you seeing?
Yeah, I mean, the one thing that is most scary to me about all this is the phishing attacks, or the social engineering, because a lot of, we can have automated scans and pen tests, fix all our tech. If we could if we had unlimited money, we could do so much to protect the information. But at the end of the day, we can't do anything technically to prevent staff from clicking on that damn email that contains a virus. I see these all the time. And the one thing I want to remind everybody on this call about that is, sometimes what we're seeing is that the cybersecurity policies you purchase do not cover social engineering attacks. So we are finding some of our clients caught in a situation where they think they have cybersecurity insurance, but it doesn't cover that incident where somebody makes a mistake and clicks on that link. So it is a good idea to talk to your broker, because even if I read those policies, I wouldn't understand them. To talk to your broker to make sure your coverage is broad enough.
Yeah. Stacey, if I can, just about the security policies, you're absolutely right. I've seen that recently as well, where we had a client with an event, and it ended up, they weren't covered, right, because it was human error,
Right.
and it was a phishing attack. The other thing that we see quite often, and I know that cyber insurance can be extremely expensive, but the other thing we see quite often is many organizations are underinsured. And if you really look at your policy, you really need to think about what would it take if we had a breach or an event to really clean it up? What's all involved? Is $5 million in coverage, or 2 or 10 or whatever you may have, good enough? Oftentimes, when you sit down and you think about what it will actually cost, most organizations, or a lot of organizations, are underinsured. So I encourage all organizations to, take a look at your policy and think about what would it really cost if we had an event, and am I covered as much as I think I am?
Absolutely. Thanks, Ed. So let's keep going on some questions that we've gotten, and I guess one is around in 2017, Governor Cuomo instituted DFS 500, which was really for financial institutions. And so I think that what are the thoughts here? And Stacey, maybe if you want, I can start with you. The proposed regulation here for healthcare organizations versus what it was for those financial institutions, which I even know has recently been amended, last year. So can you give a little bit of perspective there? And maybe Ed, I'll come to you after.
Yeah, I mean, Ed might have more on this than me. I haven't done an analysis to compare the two. It all is a big cry for those industries that contain a lot of sensitive information to protect that information. And we see the DFS regulations do cross over into healthcare sometimes as well, for entities such as MLTCs or other types of providers that might fit into the definition of HMO under DFS. But, it's all pretty much the same concepts, I think, and Ed might know more specifics, but you're gonna look at your environment, you're gonna identify your vulnerabilities, and you're gonna come up with strategies as to how to protect them and monitor the protections that you put into place. So that basic philosophy kind of covers both. I think DFS is obviously a more mature regulatory scheme. So it's a little bit more thought out and been revised and all that. So maybe we can learn from it. But the specific analysis I have not done to compare the two. Ed, did you have any other
Yes,
thoughts?
sure. Yeah, no, you're spot on. I mean, without going, kind of line for line, and I've worked with DFS 500 a lot, within a lot of organizations. You're spot on. This is really for those targeted entities, right? Healthcare, and previous to this with the DFS 500, financial institutions that house a lot of personal information, getting them to make sure they're doing the right things. If you think about this, what both of them do, and there are some differences between them, right? But what both of them do is they kind of codify leading practice and say, we expect you to have this in place. We're mandating it now. And that's really what they do. And, it's I think this is kind of the healthcare version of 500. But I mean, there are some differences. But that is exactly what it is. You hold a lot of personal information. We have to protect the citizenry and the general public and make sure that information is protected appropriately.
Great. And so maybe we switch a little bit to implementation. And clearly, for the folks on the line today, they're thinking, this has come out of nowhere. There's a lot to do. We'd have to do in 12 months from the final regulation. What are some next steps that we would be suggesting that healthcare organizations, these general hospitals take? So Ed, maybe I'll start with you. I know Stacey hit some of them in the her introductory slides, but maybe we can fine tune that a little bit and just give some insights to folks that are, concerned that there's a lot to do and not a lot of time. And certainly after that, we'll get to the funding of that. So,
Yeah, the funding's always the fun part, right? What I would say is this is about what you can do right now is get to your basic blocking and tackling and pay attention to what I refer to as cyber hygiene, right? Look at those leading practices, your policies, making sure you have multi-factor in place, making sure that you are doing, you're patching your systems, all those types of things that, and Stacey alluded to them or talked about them directly in the slide deck, but that's where I would start, right? And when you look at your policies, modify what you have to address that non-public information, not just PHI, right? Recognize and acknowledge the spread. But here's what I would tell you about your policies as well. Make sure that they're not aspirational, right? You can say, we do this. The minute you say we do it, or we must do it, it should be in place, right? So take a look at those policies, get them ready to be updated, but also as you're doing those updates, think about where I now have to extend that control, right? So, I need to go encrypt other servers, or I need to go extend multi-factor to other areas. But take a look at those policies and standards, okay? Make sure that you're talking to your governing body. Make sure that they understand their obligations and what's coming their way. If you haven't been reporting to them annually, or, I have clients that do it semi-annually, they'll do it every 6 months, or even quarterly. But make sure they know what their role is going to be and what's going to be coming at them. You may want to get them training, right? You may want them to get some training so that they better understand when the chief security officer comes and talks to them about risk, they can ask, well-informed questions. Get your budgets in place, all of those things. Start taking a look at your vendors, right? So we've had some questions about BAAs and how to make sure your vendors are aligned. Start to update those documents. If you are going to have to extend your third-party risk program to vendors that maybe don't have BAAs, are you going to make make them sign them, or are you going to have a separate kind of questionnaire, right? So, and then last, look at your incident response plan and exercise that.
Great. I guess, Ed, I'll let you take a break here to get your breath. But Stacey, anything else as it relates to what organizations should be thinking about here as they embark on this once the regulation goes final, and certainly up until then as well?
Well, I'm going to tell you that forever and always, I'm now going to steal Ed's statement. Make sure your policies are not aspirational. That is awesome.
Yeah.
And I won't
use the word
that.
auditable, but in some cases they have to have evidence behind them that they're, because I know that part of the regulation is that you have to be able to provide those policies and procedures and have them be operating effectively, or being able to document areas that you need to fill in the gaps, right?
Right. So if you're going to write down that you're doing something, please make sure you're doing it. I think Ed covered a lot of the things that I would have recommended doing. The vendor issue, I think, is going to come to a surprise to some entities. I know some entities send out questionnaires, have certain language above and beyond what's required by HIPAA and their BAAs, but not everybody and not everybody consistently. That's going to be a big area of change, and an important area. It is important because, once again, I'm seeing vendors cause breaches every day. So you want to know that your vendors aren't just signing that BAA and saying they're doing it and they're not. There is an obligation now under these proposed regulations that you actually do due diligence on your vendors. So this implementation of these regulations is going to be a little costly. And I think you're going to have to start prioritizing and thinking about your numbers as to how you're going to implement that. And then just one additional thing that I think Ed touched on earlier, but I just wanted to emphasize, your staffing, you're going to need to make some decisions about, because you're going to need a CISO. He's going to need support staff, even to do all these review of vendors. I don't know, you probably don't have the staff to do that now. So just keeping in mind, you can outsource some of this. You can hire people, whatever works best for your institution, but that takes time to implement. So I think you should start thinking about it now, how you anticipate being able to pull this off.
And it's not only the implementation of that, it's also the ongoing monitoring after you've put this in place. Yes. And so I think resources overall beyond the CISO is a great point that, organizations are going to think about. And I think it was helpful, obviously, that they said that you can outsource this right. This work and this assistance and everything. So I think that was an important point. So you hit on something, Stacey. Let's move into, everyone on the phone here does not have a lot of extra resources and funding sitting around now to implement a costly regulation. So let's talk. There was discussion in the proposed regulation about cost. And so I don't know, Ed, maybe I'll bring you in here about what they said about cost and kind of your perspective. And then Stacey, I'll come back to you.
Sounds good.
Sure. As Stacey said early on, it's not going to be cheap. The estimates that are out there are that it could be between 250 and 10 million, and I know that's a huge range to develop and initially implement, and then anywhere from 50,000 to 2 million more to maintain on a yearly basis, depending on the size and complexity of the organization. I think reality is, 250 is low, even if you're a small organization or a smaller organization. And I think 10 million, unless you have nothing in place today, is probably a huge number. I think the sweet spot is going to be somewhere in the middle there, probably between $750,000 and maybe 5 million to narrow it down a little bit. And then, to maintain it, this is where, again, I would encourage organizations to really look at what you need and pick a solution that will grow with you, right? There's nothing wrong with, as Stacey said, first maybe you source a chief security officer if you don't have one today. You source someone to help with third-party reviews. And then as you grow, as the program grows, you can always bring that in-house. But I would look at, how do you manage that cost and get what you need versus just assuming, well, I need to hire, 5 people and we need to put all these processes in place. There are organizations and firms that can assist you with that and do that on a regular basis for organizations where they will do third-party reviews. They will do fractional chief security officers, chief security architects, things like that. So I would encourage everyone to take a look at, what they really need and get what they need, not necessarily, rushing to try and hire a full complement of people.
Thanks, Ed. Stacey, let me bring you in if you have any other thoughts there. But we know that they are supposedly appropriating some funds in order to defray some of these costs. And so I think, because I'm sure a lot of folks on the phone are saying, well, that's all great. We can always go hire people, but, we don't have the money to do that at this point. And so maybe can you talk a little bit about the fund that they created? And again, we don't know a lot and when it's going to be open for grant applications, but can you maybe talk a little bit about that so folks understand that there might be a resource available to them?
Right. So the proposed regulations do contemplate that there will be a $500 million fund available to assist hospitals, general hospitals, into coming into compliance with these regulations. However, we have nothing yet as to who's getting the money, how do you win the award, Is it only distressed hospitals? Although in New York, that's most hospitals. Is it all hospitals? Like, how do we get this additional funding? And we simply don't know yet. We have to keep our eye on it. It's a good idea for you to keep an eye on it. And I guess the only thing I would have added to Ed's discussion about the money is this. It's an analogy. I'm going to tell you a little story. Many years ago, I handled a breach. It was like 2,000 people. The privacy office and I sent out the notifications. We sent the press releases. And the next day, I had a screaming CEO who opened up the paper and read that her hospital had a breach because I forgot to tell her. So my point of this story is, you security officers listening or IT folks listening to this presentation, you got to tell your finance people that this is coming down the pike and they need to prepare for it. Don't let these finance people out, because this is happening at some point this year, and there is going to need to be money contributed to it. And then the financial folks can keep an eye on the grant applications or whatever else comes out. But everyone needs to be aware of the financial burden that this is going to impose. And the DOH is not denying that is out there, that this is going to be costly.
Thanks. Stacey, while I have you, do you mind hitting one question and answer here? There was a question around the comparison of this new proposed regulation and the Cures Act. Is that something you could hit on?
Yeah, I had mentioned that a little bit earlier, that the Cures Act, or the information blocking, really pertains to the exchange of information, promoting that. This regulation is about protecting the information while it's being exchanged. So Cures is more about access and that type of thing. It's a little different.
Great. I think one question, I'm looking at some of our questions, and I think that one that comes up that's probably a little alarming to folks, and maybe Ed, I'll come back over to you, is this concept of the 2-hour rule, which, I know that Stacey hit on it a little bit. Again, there's a definition around it. It's 2 hours after you've actually determined that it could be materially right. And so can you maybe touch a little bit on that from your perspective, if you were advising a client on how to approach that? Because it's pretty aggressive, I would imagine. But I know what the purpose and the rationale for is it, but if you're advising a client, what would you say to that?
First, call Stacey.
Thank you.
Second, call me, or Stacey will call me. No, I've lived through this. Okay, so I've been on the receiving end of the clock is now ticking. I have to call the regulator. Okay, as a deputy chief security officer, I maintained our relationship with our prudential regulator, and here's what I would tell everyone. First of all, understand what material means. Material to you and your organization is not the same as material to another organization. Okay, so make sure you understand and have a definition of material. I wasn't joking about make sure you've called Stacey or your attorney. Okay. They should be involved right away. As much as I'd like to be the first phone call, your lawyer should be, your attorney should be the first phone call. And then make sure that you have an incident response plan that's been tested. And we do this with organizations all the time. A lot of organizations say, yes, we have a plan, but they never take it off the shelf and walk through it. Make sure that plan is you've actually walked through it, and you can say, okay, we've had an event. The IT team and legal are looking at, what actually happened. Okay, we now know that records have been exposed. Is this material or not? Who do we call? Who's making the phone call? Test that. Walk through it and as a tabletop exercise in your boardroom, right? Have someone come in and walk you through that so that you can see how it actually works. Those are the big things. Understand what material is, and make sure you've tested that. You have a plan and you've tested it so that who's making the phone call, when they're making the phone call. The 2 hours isn't going to change. Once you've determined that materiality applies, you have 2 hours and that's it. You need to be able to show that you did your due diligence and that you acted appropriately. And that's where part of that plan is also, as you go through your investigation or your analysis, documenting time, everything that's happening. That's part of a fully vetted plan. And that's what I would tell people. Test that now so that you're not testing it when something actually happens.
Absolutely. Thanks, Ed. And Stacey, maybe if there's anything more you want to weigh in there, I'm going to add a section B to that question. So your thoughts on the 2 hour rule, but also does the hospital also need to report to others like the OCR and possibly the Attorney General under the Shields Act? Can you maybe add that to your response?
Yep. So yes, these regulations do not do away with those reporting obligations. They are in addition, excuse me, to those reporting obligations. So if you have something that's a breach of PHI, you're going to have to tell the OCR, you're going to have to tell the Attorney General, and all those other organizations, but it's one form you submit, and you're going to have to tell the Department of Health. So this is an additional reporting obligation for you. What's interesting also is that, say you have a breach of your HVAC system that means your hospital can't operate or something to that effect. That is actually not reportable to the OCR, probably not reportable to the Attorney General, but under these new regulations will be reported to the DOH if materially affecting your operations. So keep in mind again that these regulations are much broader than just PHI. And one finally also, I guess one example additionally, say you have a breach of your employees, your HR, I see this a lot, and it involves because they get into your CFO's email account and he has all their tax information. Now, that's not reportable to the OCR, but it is reportable to the Attorney General and might be reportable to the DOH depending on how you analyze it. So every scenario now, you're going to have to consider all three of these reporting obligations and maybe others, joint commissioned or something like that, depending on what happens. But this is an additional level of consideration as to what has to be reported.
Perfect. Thank you. Hey, I want to hit on one question that came in, Stacey, with you, if you don't mind. And I think it's an important one. And I think maybe alluded to it up front, but is this regulation for hospitals only or any other or any healthcare organization like health insurers, laboratories, and others? Maybe you can kind of talk about the general hospital concept.
Right. So once again, these regulations only apply to general hospitals, meaning hospitals that have an emergency department, just to quickly define them. And these regulations do not apply to other types of healthcare providers in New York. Obviously, other types of healthcare providers need to comply with HIPAA. And some healthcare providers, particularly like MLTCs or insurance plans, are responsible to DFS. Right. But these particular regulations are only for general hospitals.
Okay, great. Okay, and so Stacey, I'm going to follow one question with you, and then and that's about if a hospital complies with these cybersecurity requirements in the regulation, can they avoid class action lawsuits if the hospital still experiences a breach or a cyber incident? I'm sure.
Unfortunately, no. Yeah, us lawyers are a pain in the tuchus sometimes, and we're going to sue you for lots of things. And it seems like class action attorneys are always looking for the next thing. Class action suits involving these attacks are proliferating. It's crazy. So every time a bunch of letters get sent out to people, hey, we had a breach, all of a sudden someone's looking for a class. So these regulations create a defense for you as to those class action suits. A lot of them, once a class is approved, everybody settles. But I'm starting to see providers push back and say, no, I don't care that you formed a class. You have no damages. We had a HIPAA compliance program in place and stuff happens, so we're not paying you. But nobody's really strong enough yet in that regard. I'm looking for the suits that come down, and hopefully that's the argument that's made, and these regulations will support that type of argument.
Great. Ed, anything on that? I was going to hit another quick topic. We're coming up on the 3 minutes left.
No, Stacey's clearly the expert in that space.
Yeah, I figured.
I tried to avoid playing lawyer, right?
Yeah.
Although it was good to hear that I did understand the difference between HIPAA and the Cures Act. So I was, I at least had them right in my head. So
Ed, let me hit you something on around encryption and whether or not there's any alternatives to encryption in the same way that encryption is addressable under HIPAA, because I know that this is can be a big topic for folks.
So yes, the short answer is yes. The regulations allow for alternative or compensating controls as long as they've been reviewed and approved by the CISO or chief security officer, right? Here's practically what I would tell everyone. And I tell this to two-person shops to, I've had clients with 20, 30,000 employees, okay? When some of these privacy regulations were passed initially, encrypting computer equipment was very difficult. There was no way to centrally manage it. There was, you in some cases ran as much risk of losing your data if you lost the encryption key as if, it was exposed, right? Encryption was kind of in its infancy. It's come a long way. I mean, my own personal laptop, I can turn on encryption, and that way, if the laptop is lost, if I leave it somewhere, no one's going to get, whatever I've kept on it. Okay. I would tell people that compensating controls can be appropriate, and in some cases are very appropriate. However, I would take a long, hard look at why you can't encrypt, because today you can centrally manage encryption. You can on end devices, you can centrally manage it on servers, or in the cloud even, you can encrypt your data and centrally manage that. It's a lot easier to do. So yes, there are alternatives. In some cases, they are appropriate. You have to review them. I take a long, hard look at why, because having the information encrypted is probably going to be your easiest path towards I did the right thing. But I'll leave that up to Stacey and the legal teams to argue about. But from a cyber and risk perspective, I would err on the side of encrypted if I could.
Great.
I totally agree.
Excellent. Well, great discussion. We're up at the top of the hour. I know there's one question around a CISO kind of outside these proposed regulations. We will get back to you on that one question, but I think we got the rest of the questions in the Q&A. Again, thank you for everyone for joining us today. Hopefully this was helpful. If you want further details or you just want to have a discussion with either Stacey, Ed, or myself, contact information should be included on the webinar. But again, thank you everyone for joining us today, and we hope you found this helpful. Have a great day, everyone.
Bye.
Thank you.
Thanks, everyone. And just a reminder that all of the event materials can be accessed at any time after the presentation with your audience join link, including the slides, presentation recording, and related content. Thank you and have a great day.